Dr. Ken Landa. Thanks for watching. Let's talk about dry mouth. Now, it's been said that saliva lacks the drama of blood and the sincerity of sweat and the emotional appeal of tears. But a lack of saliva can sort of get your attention, and very quickly. And unfortunately, it's a significant problem, especially as we grow older. Now, the symptoms that are associated with dry mouth can range from just mild oral discomfort to significant conditions that can compromise the quality of life and your health. So it can alter your speech or your ability to chew and swallow and taste, lead to burning mouth and burning tongue, cause you to sip water when you're eating your meals, even change your nutritional status because you avoid certain kind of foods. Can lead to halitosis because of an overgrowth of bacteria, cause problems wearing your dentures, can lead to an increased number of dental caries, and can lead to overgrowth of yeast inside your mouth. When we talk about dry mouth, we need to talk about two different conditions. One is the subjective complaint of dry mouth. Frequently it occurs without any signs of lack of saliva or hypofunction of the salivary glands. The symptoms can simply be due to a change in the quality or quantity of saliva. Maybe it can go from watery to more mucus, even without a change in the amount. Many people have xerostomia, and they also have a decrease in salivary production, but the two don't run together in parallel. The incidence varies depending on the study. So we talk about the incidence of xerostomia and the incidence of salivary gland hypofunction, and interestingly, both of those conditions can occur anywhere between about 5% and 50% of the general population. Now, overall, when we evaluate people, it seems like both of those disorders affect individually about 20% of the population, but that number increases to about 40 or 50% of seniors. And part of the problem associated with aging, of course, is the glands don't function as well as they used to, but as you get older, you have a tendency to take one drug or multiple drugs, polypharmacy we call it. And the more drugs you take, the more likely you are to have a dry mouth. Now, even though each of those conditions occurs in about 20% of the population on average, if we're talking about people below the age of 65, they happen together, both the xerostomia and objective decrease in salivary production, only in about 5 or 8% of the population. And just because you have the condition of xerostomia doesn't mean you're going to have it forever. Theoretically, about 25% of the people with xerostomia merge back into the normal population, and some obviously with no complaints are going to end up with complaints. Now, what are the normals for salivary function? Well, it seems that the production, at least, is about 1/4 to 1.5 quarts a day. And we can divide that into stimulated and unstimulated fashion. So unstimulated salivary gland production, that's going to occur when you're just sitting and reading or looking around or doing something, but you're not chewing. You're not chewing gum or eating a meal. Well, in an unstimulated state, you make about 1 teaspoon of saliva every 12 to 14 minutes. It's abnormal if you make a teaspoon about once an hour. In a stimulated state, when you're eating or when you're chewing gum, you make about a teaspoon of saliva every 2.5 to 3 minutes, and it's abnormal when you only make a teaspoon about every 7 minutes. Now, there's a circadian rhythm to production of saliva. During the nighttime, the saliva production rate falls dramatically, falls to between 0 and 1 teaspoon an hour. So extremely small amounts of saliva produced overnight. That's why a lot of people, about 38–40% of the people, seem to wake up in the morning and say, I got a dry mouth, versus only about 9% who complain that they have a dry mouth when they're eating. Now, the typical complaints of dry mouth occur when the salivary flow rate decreases by more than 50% of what it typically is. But since it's such a subjective complaint, and it varies to a large degree over a period of time, in order to rule out some of the transient causes, you have to have the symptoms for at least 3 months before it's considered a real problem, because sometimes it might just be due to anxiety or dehydration, or maybe you happen to be a mouth breather. And when you're a mouth breather, you're going to dry out the mouth on normal circumstances unless you have super high humidity. And frequently, women, as they go through the menopause, they get dry mouth. Well, where does the saliva come from? It comes from a variety of different glands. Now, we have paired major glands, and the major glands are the parotid gland and the submandibular gland and the sublingual gland, obviously one on each side. And then we have the minor salivary glands. And the minor salivary glands, there are somewhere between 800 and 1,000 of those, and they line the inside of the cheek and under the tongue and on the soft palate, some on the hard palate. And over a period of time, we're going to have a decrease in the volume of the cells by 20 or 40%. And some of them are going to be changed into fatty and fibrous tissue over a period of time. And we're going to have the most notable decrease in output on the most important salivary glands, the submandibular and the sublingual glands. Not going to have much of a change over a period of time in the parotid glands or in the minor salivary glands inside the mouth. Now, if we look at the unstimulated saliva, 75% is going to come from the glands down here, the submandibular and the sublingual glands. Only about 15% going to come from the larger parotid gland, and the minor salivary glands only going to make up about 5 to 8% of the saliva. On the other hand, in stimulated conditions, when we eat or when we chew gum, then most of the saliva, more than 50%, going to come from the parotid glands. That's going to be an increase of anywhere between 5-fold and 50-fold. Now, we also have to realize that we have different kinds of saliva. So the parotid gland, the gland in front of your ear, that's going to make a watery, or what we call a serous saliva. The submandibular gland is going to make a serous saliva, like that watery stuff that comes out of the parotid gland, but it's also going to make mucus-type saliva, the thicker saliva. The sublingual glands, they only produce the thick kind of saliva. The innervation, the nerves going to the salivary glands, very important. So we get the parasympathetic nervous system, that's the acetylcholine. Well, that's very important because that stimulates the gland to make high volume, the serous watery type, that's very low in viscosity, doesn't have very much mucin, doesn't have very much protein. So we talk about the anticholinergic drugs like Benadryl that are going to decrease the saliva. So we talk about a cholinergic burden. The more drugs you take, the less saliva you're going to make. And then we have the adrenergic stimulation. That's adrenaline and noradrenaline. Those are the alpha and the beta stimulants. They produce a low volume, high viscosity type of saliva. There's very little mucin when the adrenaline is the stimulant. There's high mucin when we have the beta stimulants. Well, what does saliva contain? About 98 or 99% of saliva is just water. And 1% makes up the electrolytes like the sodium and the potassium and the magnesium and the zinc and the calcium and the phosphate, but it also contains a little bit of urea and some ammonia and some protein and some lactoperoxidase and some lactoferrin and even some immune globulins, especially from the parotid gland, the IgA. And then it also contains some of the B cells, the lymphocytes that make the antibodies, and the plasma cells. Then we also have a little bit of mucin. The pH, the acid-base balance, what's pretty neutral in the saliva. And that's important because it needs to be neutral to activate the salivary amylase and the lipase. Those begin the digestive process. And also keeps the equilibrium of the bacteria, the microbiota inside the mouth, and prevents the overgrowth of candida that likes a slightly acidic environment. And that's what happens when we don't have enough saliva. What's postulated that it's a change in the mucin that's really what most people complain about when they talk about they have xerostomia, because the mucin sequesters the water in the oral mucosa. And the mucins are important because they coat the food and they allow the smooth swallowing and they surround the teeth and they protect the teeth from demineralization and some of the mechanical changes associated with eating. And when you get too much adrenaline, remember, you get too little of that mucin. So what are the symptoms that people complain about? Well, their lips stick to their teeth, or their mouth feels rough and swollen. They can have some pain and burning and sensitivity. Frequently develop a bitter taste or a metallic taste, or even no taste. Difficulty swallowing or chewing or speaking. Food gets stuck in the throat. Some food particles stay behind in the mouth, and that may lead to halitosis, or bad breath from an overgrowth of bacteria that you find in the morning. It can be painful to wear the dentures, ulcers in the mouth, or hoarseness. Some people find so much trouble eating that they start to lose weight, and the symptoms are increased during the nighttime hours, because remember, you decrease the amount of saliva that you produce. And in the whole process, there's going to be an increase in the amount of dental plaque, increased dental caries, and the caries tend to be around the roots of the teeth and on the crowns, especially around other fillings. You have a decreased saliva, so that's going to lead to a decreased buffering capacity. So you're going to want to snack because you have this symptom of dryness. So unfortunately, most people tend to snack on sweet foods or acidic drinks or sugary substances, and that's going to further compromise the dental health. It's going to change the microflora in the mouth, lead to periodontal and gum disease, increased number of extractions. On physical examination, when we look at the mouth of a person who has dry mouth, we frequently find the saliva that's stringy or ropey or even frothy. There's a glassy appearance of the oral mucosa. There's no pooling of saliva underneath the tongue. When we look at the tongue itself, it can have a loss of papilla, those little fine surface hairs from the surface of the tongue, oftentimes a fissured tongue, sometimes traumatic lesions because of the irritation from the food on the buccal, on the inside cheek mucous membrane, and on the lateral border of the tongue. Sometimes we see the candida growing on the tongue, coating the tongue white. Sometimes the mirror, the finger actually sticks to the oral mucosa. And sometimes people who have dry mouth have an associated condition of dry eyes. They can have a gritty feeling in the eyes, the inability to produce tears, can develop blurred vision. What are the complications of a decrease in saliva? We've mentioned many of them before. So dental erosions and demineralization of your teeth and dental caries that are rampant and more aggressive. We have an increase in growth of strep mutans. That's a bacteria that produces the acid that causes deterioration of your teeth. There's a decrease in the protective mucins, so that decreases the efficiency of debriding the teeth when you swallow, when you chew. In the elderly individuals, there's another problem because they oftentimes lack the manual dexterity to use a toothbrush, especially if they happen to be in a chronic care facility. Well, with decrease in saliva, you have problems with your dentures irritating your mucosa. And if you have partial dentures, they can harm the remaining teeth. There's inflammation of the mucosa, susceptible to friction and laceration. The tongue becomes extra thick, sometimes fissured, traps bacteria and food particles. Some people complain of an altered taste sensation, metallic taste. Sometimes they have a difficult time smelling things. They have what we call dysosmia. And there's halitosis because of the bacteria I mentioned that have increased growth on the tongue, especially a biofilm on the back of the tongue, and then there's gingivitis, periodontitis, and the candidiasis. Have to be careful about treating the candidiasis because oftentimes, typically we use clotrimazole or nystatin oral treatment, but they contain sweeteners, so that's not very good. So what's the cause of dry mouth? The cause of dry mouth has a lot to do with your age and your genes, but at least 500 medicines can cause dry mouth. A variety of diseases can cause dry mouth. And if you've had radiation therapy, oftentimes for cancer of the head and neck, that can kill the salivary glands. What kind of medicines might precipitate problems? Well, antihistamines, so if you're taking a Benadryl or any similar kind of medicine, or an antidepressant, an SSRI, Prozac, or similar medicine, tricyclic antidepressant like amitriptyline, or an antipsychotic drug like Zyprexa or Abilify. You're taking a medicine to lower your blood pressure, an antihypertensive, a diuretic, or a calcium blocker, or an ACE inhibitor. Even taking non-steroidals like ibuprofen and naproxen can cause the issue. Or a proton pump inhibitor like Nexium or omeprazole, or the opioids or the decongestants, steroid inhalers, medicines for overactive bladder, or scopolamine because you're seasick, or you get problems when you're in a car, or certain kind of eye drops may lead to dry mouth, synthroid hormone you take because you have an underactive thyroid, or medicines for COPD, chronic lung disease, or even cancer chemotherapy. The likelihood of you taking one of these medicines increases a lot as you grow older. So if we look at people who are 20, 30, or 40 years of age, they're already taking one or two drugs, about 25% of the population in that age group. If we look at senior citizens, at least 90% are taking one or two medicines. And then we also have some other problems. We have mouth breathing or dehydration. A lot of people go on these crazy diets and don't eat or drink for 24 hours. Well, if you don't eat or drink for 24 hours, you're going to decrease your unstimulated salivary flow by about 90%, 90%. And then we have people who smoke cigarettes or drink alcohol, people with anxiety or depression or stress or malnutrition, people with eating disorders or celiac disease. Actually, in celiac disease, dry mouth might be the only symptom. Poorly controlled diabetes leads to dry mouth, and a variety of autoimmune diseases. And then we have HIV infections, and hepatitis C, and the Epstein-Barr virus, and CMV. And there's an interesting condition known as Sjogren's syndrome. Sjogren's syndrome is where you make antibodies to certain glands, and the glands happen to be around your eyes and in your mouth. So you get a dry mouth and you get dry eyes. And additionally, you can get some joint pain and fatigue. It can be primary without any other condition, or secondary where it's associated with rheumatoid arthritis or lupus or scleroderma. It's a very common condition. It affects somewhere between 0.5% and 1% of the population. It tends to occur in women more than men, about 9 times more frequent in women. Average age of onset is around age 50. How do we diagnose the condition? Well, originally it was thought it was a visual examination, just look, and if you don't see saliva in the mouth, that's all you really needed. But there's more to it than that. So in the 1980s, the 1990s, got away from just the look of the mouth, the lack of saliva pooling under the tongue, and we started with some questionnaires because the symptoms are the most important thing. That's what we really need to address. What are the patient's complaints? So we could ask a simple question: how often does your mouth feel dry? But that requires the integration of the perception and the experience and the behavior, and it really isn't a very good solitary basis to make the diagnosis. And actually, the positive predictive value of the answer to that question is only about 50%. So then they started making these questionnaires. Some of them had 11 questions, some of them had 5 questions. So the questions would be: do you have difficulty swallowing? How much saliva do you make? Do you make enough? Do you make too little? Do you have to sip water when you're eating? Do you have trouble eating dry food? Do you wake up at night to drink? Do you suck on lozenges or sweets or chew gum to relieve a dry mouth? Do you have difficulty eating certain kind of foods? Do you also have dry eyes? Well, the response to those questions typically is on a visual analog scale where you put a little mark on a line and that determines where you fit, or you can give a numerical answer, maybe 1 to 5. They're all better than simply saying yes or no. We don't need any kind of blood tests unless there's a suspicion that maybe you have an autoimmune disease, like that Sjogren's syndrome. Then we get an anti-nuclear antibody, rheumatoid factor, anti-SSA or anti-SSB. Those are blood tests for antibodies. Don't need a biopsy unless a person has condition that might suggest Sjogren's or amyloidosis or sarcoidosis that we can't otherwise prove. And we can look at the salivary flow. We can measure the salivary flow after an overnight fast, or after you haven't eaten for at least 2 hours. Rinse the mouth with water before the test. Remember that there's circadian rhythm, so we want to do the test at the same time of day all of the time. And we can either measure the whole saliva, or we can measure the unstimulated, stimulated saliva, We can allow the saliva to drain from the mouth simply by tilting the head forward, keeping it that way for at least 5 minutes. We can use some pre-weighed cotton balls that put in the mouth, or absorbent strips at the floor of the mouth. Can be measured by the spitting method or the suction method. Can be measured stimulated by chewing gum, or putting some paraffin wax in the mouth and chewing that, or even stimulating the saliva flow with some citric acid, 2% citric acid, that we put on the sides of the tongue. Whole salivary glands can be measured, or we can measure just single salivary glands. So we can look at the parotid production, because the parotid production is going to come into the mouth through Stenson's duct, the submandibular gland through Wharton's duct, or we have about 8 to 20 Rivinus ducts from the sublingual glands. Minor salivary glands, they're just 800 to 1,000, so we can't measure them very easily. We can measure by weight, that's the most accurate. We can measure by volume, but there are a lot of bubbles, and that sort of makes things a little bit different. So now it brings us to the question of, once we've established that you complain of a problem, how do we address the problem? Well, first, we look at the medicines you're taking, and if there are some medicines that can be reduced or substituted, that would be great. We look at some of your habits. Do you drink sufficient water? Do you suck on ice cubes or sip water? How about your dental hygiene? Because if you have dry mouth, we know dental hygiene is extremely important. You need your plaque removal. You ought to see the dentist at least every 3 or 6 months. Brush at least twice a day. Floss. Use alcohol-free, fluoride-containing mouthwash or mouth rinse, or chlorhexidine mouthwashes. Avoid cigarettes and avoid tobacco and caffeine. And avoid the things that are hard to eat, like the crackers and hard bread, crunchy foods. You want foods with a lot of water in them. Fruit and fish. You want to avoid sugary drinks. You want to avoid the regular sodas. You want to avoid fruit juices because they have an awful lot of sugar in them. You should avoid irritating dentifrices. You should chew some sugar-free gum or candy. Clean the dentures, obviously. Clean them with chlorhexidine overnight or with a gel twice a day. Use a child's toothpaste, or use a toothpaste with sufficient amount of fluoride. Now, normally, the fluoride in toothpaste is somewhere between 500 and 1,000 parts per million. But they do make toothpastes with 2,800 to 5,000 parts per million. Tend to be prescription, tend to cost a little bit more, but with coupon from GoodRx, you could get Prevident that has 5,000 milligrams, or 5,000 parts per million. You could get the Prevident for $8 to $10 a tube. You should use a significant fluoride mouth rinse at least once a week. Use a nighttime humidifier. Dental sealants are important. Dietary counseling, and you treat your candidiasis if you develop that. Use topical treatment, but topical treatment contains the sucrose, so for the most part, we probably use systemic treatment. Obviously, clean anything that's in your mouth that's removable. The treatment that we have available doesn't work very well. So we have the salivary stimulants, and we have the saliva substitutes and the mucosal lubricants, and we have what are known as the sialagogues, medicines that you take by mouth, pills, that can stimulate the production of saliva. So the salivary stimulants, most commonly, these are not prescriptions, these aren't even drugs. It's chewing gum and mints and lozenges and artificially sweetened candies. They stimulate the saliva. Even just chewing, what it does is it stimulates the capsule, mechanically stimulates the capsule of the parotid gland and pushes out some saliva. We have oral sprays and gels and mouthwashes and toothpaste and olive oil and betaine and xylitol. And sometimes we can use some malic acid or ascorbic acid. They're good if you're taking an antidepressant, maybe certain types of antihypertensive medicines, but they can cause some dental erosion, so it's not the greatest. Some other treatments are xylitol. That's a non-fermentable carbohydrate. It seems to form an osmotic gradient, so it sort of draws the fluid from the cells. That's okay. And there's profilin lozenges. They combine the xylitol and sorbitol, and then some people like yohimbine. That's especially helpful, maybe, if you're taking a tricyclic antidepressant like amitriptyline or some of the neuroleptics. Then we have the saliva substitutes. they can increase the viscosity and the mucin content, but they don't change the flow rate. They contain minerals, so they contain some fluoride and some calcium and some phosphate. They contain carboxymethylcellulose or hydroxyethylcellulose or just even glycerin. They contain flavoring usually and some preservatives like the methyl and the ethyl parabens. We have saliva lubricants that are based either in the mucin content that increases the viscosity and increases the duration of action inside the mouth, or we have the lubricating kind. They don't have any correlation with the viscosity, but they do have the ability to decrease friction. So these are things like biotin and Salivex and Lubrant and Saliva Orthana, but they probably don't work very well. And then we have the sialagogues. Those are primarily for people who have Sjogren syndrome or have had radiation therapy, but they do require that you have functional glands left. The response varies with the dosage. They only help about a third of the people, and they only help a little bit. So we have pilocarpine or Saligen. Take it orally, 5 milligrams 3 or 4 times a day for at least 3 weeks to get the full effect. Cevemeline or Avozac, that's another kind of a medicine. You take about 30 milligrams, do that for at least 3 weeks to get the benefit. But those medicines, the sialagogues, they have significant number of side effects, so they're not very popular at all because they can increase your sweating and they can cause nausea and a runny nose and diarrhea, and they can cause your blood pressure and your heart rate to decrease, and they can cause urinary frequency and vision problems. And they're not for everyone. So if you have to have chronic obstructive lung disease, COPD, or uncontrolled asthma, uncontrolled hypertension, or gastric ulcers, these are definitely not for you. And then we have anticholinesterases. These are drugs like physostigmine topically. That increases the flow from some of the minor salivary glands. And then there are a variety of other kind of therapies, sometimes acupuncture. People are talking about it. Intraoral electrostimulation with certain kind of devices. But when it comes right down to it, the Cochrane collaboration, which is a group of scientists who review medical literature, medical evidence. And what they say is basically there's no strong evidence from their review that any of the topical therapies is effective at relieving the symptoms of dry mouth. And that includes an array of all of the different kind of formulations, from the lozenges and the sprays and the rinses and the gels and the oils and the chewing gum and the toothpaste. So unfortunately, that's the story of dry mouth. It's a very common condition, and it becomes increasingly prevalent as we grow older. And it becomes increasingly prevalent as we take more medicines. And unfortunately, the currently available therapies seem not to be able to provide an acceptable solution to the problem. But for some people, a change in habit, maybe a change in some of the medicine, reduce the dose, or change to a different kind of medicine, that might be associated with some help. And that's probably about the best we can do at the present time. So anyway, thank you for watching. If you enjoyed the show, please tell a friend or consider subscribing so you'll be notified as we post new videos. We appreciate your interest. I'm Dr. Ken Landau.